It's a three-part series on chronic pelvic pain by Dr. Anthony Jan. In this three-part series, we'll talk about the common chronic pelvic pain conditions in females. We'll talk about treatment modalities and into detail look at each chronic pelvic pain condition. The common chronic pelvic pain conditions that we'll be talking about include dysmenorrhea, which is pain coming from the uterus, which is also typically associated with adenomyosis, endometriosis, pudendal neuralgia, chronic interstitial cystitis, vulvodynia, and vulvovestibulitis. Chronic pelvic pain is the presence of pain below the belly button down to the level of both hips that lasts for longer than 6 months. The main organs that pain develops from would include the uterus, which is the womb, bowel, bladder, pelvic floor muscles, and the nerves. The common chronic pelvic pain conditions are varied across various age categories. I'll start by talking about pudendal neuralgia, which is one of the common chronic pelvic pain conditions, which occurs both in males and females. But for the sake of this series, we'll be talking about pudendal neuralgias in females. Pudendal neuralgia was described initially by the French, and that was as a result of males who sat on the little seats during the Tour de France and rode for 27 miles. It's a famous French scientist who defined what pudendal neuralgia was. And a lot of the data that we have today talking about its diagnosis and treatment modalities are from the French. Typically, patients with pudendal neuralgia have pain on sitting. The pain is either intermittent as in it comes and goes, or else it develops to a point where it's constant burning pain within the pelvis, and characteristically when they sit on hard seats, it exacerbates their pain. Things that will exacerbate their pain would include intercourse. However, sitting on the toilet seat seems to relieve the pain. Typically, this pain condition gradually worsens if not attended to. The diagnosis is a combination of two things. A combination of a history that demonstrates pain with sitting, prolonged sitting, that is relieved with sitting on the toilet seat, commonly described as a burning sensation. Burning always indicates nerve pain. The diagnosis of pudendal neuralgia, however, is a combination of both a history and a physical exam to arrive at a definitive diagnosis. Other modalities that are associated with the diagnosis or confirmatory of the diagnosis would include a pudendal nerve latency test, which is typically performed by the neurologist to determine function of the pudendal nerve. The pudendal nerve arises from the back, and it actually comes from the sacral root nerves, the second to the fourth sacral root nerves. It comes from the back, it enters the pelvis from the back, and then it exits from the pelvis at the level of the ischial spine, which is medial to the sits bone. And when it exits the pelvis, it supplies three main organs: the clitoris, the vagina, and the rectum. So, as part of the diagnosis of pudendal neuralgia, a pudendal nerve block can be performed. And this typically is performed either in the office or in an operating room setting. Relief of the nerve pain after a pudendal nerve block, which normally happens a couple of days after the nerve block has been performed, is both diagnostic and therapeutic of pudendal neuralgia, which means that if the pain is relieved, it's transient though, which lasts for about 4 to 6 weeks, it is diagnostic of pudendal neuralgia. However, it is also used as a treatment modality, as an adjunctive form of therapy for pudendal neuralgia. The treatment of every chronic pain condition is multimodal, which is a combination of medication, pelvic floor physical therapy, and as I explained earlier on, the use of adjunctive therapy in the form of a pudendal nerve block. Typical medications that are used are neuroleptics, which would be examples of which would be Neurontin or gabapentin, commonly called. The use of other neuroleptics include Lyrica or the use of Cymbalta. You'd find that these neuroleptics are typically used for other pain conditions. However, in lower doses, they have neuroleptic properties to help ease the pain. Another treatment modality will be pelvic floor physical therapy in areas where The pelvic floor physical therapy. There's a role for pelvic floor physical therapy to help with coping of pain. Newer treatment modalities have recently been looked at, which include regenerative medicine, which I commonly use ray allograft, and there was also surgical intervention, which is a pudendal nerve decompression. I'll reserve the surgical treatment using pudendal nerve decompression for a later series. Ray allograft, which is regenerative medicine, has been impactful, and although it's early stages in the first 2 to 3 years that it's being commonly used in this country, the results are astounding. Real allograft, which is regenerative cells that are harvested from amniotic fluid, which is the fluid around the baby, are harvested. There are no live cells in the real allograft itself, but the amniotic fluid has growth factors, and these are harvested. These are done by a special lab down in the south of Florida, and real allograft is FDA approved for regenerative medicine, and therefore it is covered by all major insurances, including Medicare. Real allograft is used just like in performing a pudendal nerve block, which typically is performed through the vagina. Regenerative cells are injected to the pudendal nerve at the level of Alcock's canal, which is medial to your sits bone. And it is believed that in regenerating the nerve function is witnessed within 6 weeks of the therapy being produced. However, there's some patients that the effect is not within the 6 weeks and have to be followed a little bit more closely to see the full effect of real allograft.